Hi, Ben Chappelle here. Wanted to discuss a couple of telehealth programs that I came across in some research, compare and contrast. So the first program was done at Nebraska Medicine Hospital in Nebraska in the U.S. It was focused around type 2 diabetic patients, and it was administered in a post-acute setting. So really in an outpatient slash home setting, patients were at home and they could do remote upload, so more of a store and forward approach, remote upload of biometric data, blood pressure, glucose finger stick data mostly, um, to a care management group connected with Nebraska Medicine. So the patients could upload this data theoretically daily or multiple times per day. And then also included in this program was a system for um, doing health coaching, care management follow-ups, care coordination, medication consults and adjustments, also via the telehealth platform with these patients at home. And to the point was to really engage the patients in their care outside of the primary care setting to hopefully decrease unnecessary utilizations of ED and inpatient services, and ultimately to decrease hemoglobin A1C rates among these patients. Um, what they the program went very well. What they found as an interesting note is that certain subpopulations of their diabetic population were much easier to engage, and that panned out in terms of the results of lessened utilization and decreased hemoglobin A1C rates. So certain subpopulations, particularly the retired and men in general, were easier to engage, whereas younger people and the study showed that women also were less easy to engage in their health, at least in this particular module. The other study that I looked at comes from Germany. This is done a few years ago, 2014, 2015. It was actually in a telehealth in an emergency medicine situation. So this was ambulances, EMS services, ambulance services equipped with um, biometric telemetry devices, so 12 lead ECGs, blood pressure monitor, heart rate monitor, pulse ox, things like this, that they could employ specifically around certain types of emergency cases, so respiratory distress, um, heart attack like symptoms, atrial fibrillation. So if they had these cases, they could employ these telemetry devices to get data. The data could then be live streamed to a remote emergency medicine physician, who could also teleconference with the EMS personnel via video monitor, and help to diagnose the patient, preliminary diagnosis, and help to stabilize the patient in transport to an emergency facility. Um, so obviously, one of the big issues with this that they encountered with this program was connectivity issues. They did have some issues with lag of both the video and the streaming biometric data. And in particular, if you're looking at like a 12 lead ECG or heart rate information, if you're lagged enough, that can be significant if you're looking at an asystole that occurred 10 seconds ago and you're just now getting that information. That could detrimentally affect the patient. Um, so they did encounter some lag issues, connectivity issues, particularly in remote areas, but overall, they feel that the program was a success for stabilizing and treating these types of patients en route to an emergency facility. So obviously, both programs really had to do a lot around this remote monitoring, gathering biometric data remotely from patients, Whereas in the Nebraska study, it was more of a store and forward, upload your data into a program. It goes to the case management office. They review it as needed. Whereas with the Germany study, it was obviously real-time live streaming of this data to an emergency physician who was locked and loaded and engaged in that case at the moment. Obviously, settings quite different. You know, you have your post-acute sort of home monitoring and a case management situation versus your emergency medicine situation. The emergency medicine things similar to this can and have been used and are continuing to be used for things like telestroke and other emergency medicine consultations. On the one hand, the Nebraska medicine one was clinician to patient, really, that interface between them. Whereas with the emergency medicine study, it was much more physician to other clinicians in the field, the patient being present as sort of a third party at the time, but not really being an active party in that telehealth episode. All right, thank you very much, and that's it for this week.